Our next speaker is Dr. Helen Skouteris. Dr. Skouteris is a Monash Warwick Professor of Health and Social Care Improvement and Implementation Science. She's a Fellow of the Academy of Social Sciences in Australia, an inaugural Monash University Maureen Brunt Professorial Fellow, and Head of the Health and Social Care Unit in the School of Public Health and Preventive Medicine in the Faculty of Medicine, Nursing and Health Sciences at Monash University in Australia. Helen is a developmental psychologist who leads a team of 70 multidisciplinary researchers, policy, engagement, and administrative staff focusing on health and social care across the lifespan. She and the teams she leads work with industry partners to support their real-world implementation work. Together and with collective impact, she is pioneering work in the area of equity and implementation science across healthcare, social care, and education. Please welcome Dr. Skouteris.
Everyone, and I am the last person, so I'll be as quick as I can be. These are my parents, Angela and Vasilios. They were migrants to Australia in the 60s. They grew up in villages in Greece in pervasive poverty, didn't finish primary school, and were literally shipped to Australia in the early 60s, a voyage that took 3 months, because the Australian government invited Greek families to send their young children, young adults, to Australia for labour. So when they did come to Australia, they walked straight into jobs. So they would not have been able to work in Greece, and in particular for my mum, her parents wouldn't have been able to afford the dowry. So, of course, you know, it was much better for her to go to Australia and be with her siblings and get married in Australia, because the expectations were very different. In Australia, they were proxied, they didn't know one another, they were just married. So that's my parents when we went back to Greece. That's an example of pervasive disadvantage. This is my family, an example of absolute privilege. And so in just one generation, because the Australian government offered them jobs, offered their children free education. I had free tertiary education, free medical, free health in the days that my parents were living in Australia. This is the outcome of a system that actually helped those with pervasive socioeconomic disadvantage and enabled a family like this to exist now with, as I said, privilege. Both children tertiary educated, my husband also. But we live and work now, because of COVID, I do a lot of work at home, on the lands of the Wurundjeri people. We are visitors, obviously, to Australia. We colonised the Aboriginal people who owned the land. We forcibly removed them, and we forcibly removed their children and tried to make them white. We're still actually removing their children, which is tragic. Their children, the Wurundjeri family, would not probably look like this. Very different. Their children would probably most likely today not have finished secondary school or even been to tertiary, been to university, and are more likely to be in jail, actually. And if they do become parents and fall pregnant, we decide that actually we probably have to intervene, because there'll be a child protection issue there. They won't be good parents, and we need to remove those children even to this very day. So you probably have gathered, very passionate about promoting the best start to life for all children. I'm a developmental psychologist, and I've pushed my interest beyond what we know matters, you know, epidemiologically, basic research, to what we know works, doing lots of randomised control trials, many of which haven't worked actually, to now, as you probably noticed from my job title, being interested in that pointy end that we're all here to talk about, and that is translation, implementation. What we know translates, and that's where we all get very, very stuck. So as a developmental psychologist, I fell into the area of childhood obesity prevention and followed that path of what matters, what works. And then with young people who are living in out-of-home care, so they've been removed from their parents because of sexual, physical or emotional abuse. Developed a healthy eating, active living program because they are 2.5 times more likely to be living with overweight and obesity. So developmental psychologist designed a very behavioural top-down approach to overweight and obesity prevention. And of course got lots of funding because I was an important person who decided to do work in this area. And as soon as I started researching in the area, there was complete resistance from the carers of these young people who know them intimately well, because they themselves have potentially experienced, have the same lived experience as the young people they're looking after, and are also more likely to be living with overweight and obesity as well. So my idea of what needed to be done, and my colleagues' idea, because there were 4 of us who were psychologists, was completely stigmatising, completely discriminatory. We had never worked with these young people. We had never been part of the sector, and yet we were given federal government funding to go in there and fix the problem because, of course, I know it all, don't I? And I should have worn this T-shirt. Don't argue with me because I'm a professor and I clearly have got it right. Well, I had it very, very wrong. And so that was around 2012. And I linked with sociologists in the UK who were absolutely horrified that I was focused on obesity prevention. And I was absolutely horrified that they wouldn't be. But, I was coming in from a health model. We need to do something to support these young people so that they're not living with obesity. And they made me understand and realise that actually, if you stop, Helen, and think about the importance of food and physical activity for creating a sense of belonging, a sense of trust, a sense of value, you're more likely to be able to get your message through and not use the word obesity or weight or, eat your vegetables and be physically active. And that's exactly what happened. And so, you couldn't go into my mum's house without being fed. And I was devastated that I hadn't thought about how important food and physical activity is for these other sociologically driven factors, not the medical reasons, the reasons that are much less stigmatising. And so that was the point in my career that I decided I need to stop thinking that I can drive research questions, and I need to become much more strategically focused in prioritising research that actually matters in the real world. So I stopped and I listened to the sector, and I engaged and involved young people with lived experience of out-of-home care. Those young people ended up in my team. And from that point onwards, I took a back seat and I enabled them to lead the research, to co-design and co-develop healing matters in a way that made very good sense to them and that was meaningful, applicable, relevant for the sector. And so Healing Matters is a success story. It was taken up by the Victorian government. I was given millions of dollars to scale it. It is now best practice in Victoria and in South Australia and in parts of New South Wales and Australia. It's award-winning, it's won awards, but the reality is, and they've also funded us now to do health promotion guidelines, so we've really changed the outlook of out-of-home care in terms of health promotion. But the reality is that not all children are benefiting, not all young people are benefiting, and Healing Matters and an equity process was not embedded from the outside. It was an afterthought. So we developed Healing Matters and we did do co-design, but it was a particular group of young people. Of course, they're not going to be representative of everyone in out-of-home care. We left behind the First Nations young people who are overrepresented. And yes, I did that. And we left behind young people with disabilities. We left behind our LGBTIQA+ young people who are living in these homes. And so what we've done now is changed all of that, and we've created Healing Matters that is much more inclusive. But as I said, it was an afterthought, and that has never sat well with me. So we know that despite programs such as Healing Matters that are focused on populations who are living with most disadvantage, health inequities and the widening gap between the wealthy and the poor are megatrends that will definitely destabilise societies. It's already happening. And of course, Australia is not exempt. Australia is a high income country. We've been, hearing from low and middle income countries. So Australia is a high income country. So there's no excuse. Over 700,000 children in Australia, 18% roughly, are living below the poverty line. So to address pervasive poverty and disadvantage, we need to build the technical knowledge and competency skills for effective translation through advanced theoretically informed implementation science. I don't need to convince you of that. And this is where equity matters and must be an explicit focus, not an afterthought. So, you've all seen that. We do all of our research and then we get to this point where it's so complex and so messy, and we do really want a miracle to happen, but we have to embrace that complexity. And despite hundreds of implementation frameworks, theories, models, the how to use implementation science to advance equity is still largely unknown. So fortunately, I was awarded a Maureen Brunt Professorial Fellowship by Monash University to tackle this global issue. Maureen Brunt was the first woman professor in Australia and the first woman chair of economics in Australia. And that was only, I think, in the 80s. So it wasn't that long ago. And she was working class. So it's a real honour to have been awarded that professorial fellowship. This is the team. There's 6 of us here today, and I want them just to put their hands up so you know who they are. They've come from Australia. And there's one over here. But there's obviously, as you can see, a lot more of us, and I do acknowledge all of their support. And our vision is to develop Australia's first programmatic multi-sectoral study of equity-centred implementation science across health, social care and education. I'm not going to go through the details in this slide, but I'll give you an overview of the program of research that we've embarked on. And of course, it begins with lived experience expertise, and we have developed our lived experience expert network, and they will literally walk with us side by side, and we will be listening intently to their voices, but also including them in facets of research with different roles. So it won't be just, okay, we're just going to have a little bit of an interview here or a focus group. It will be much, much more embedded, and we're very excited about a potential virtual collaboration hub as well, so that we can literally work with them collaboratively. This is very exciting work around a multidisciplinary implementation model for initiating change. We've called it MIMIC. And really what we're trying to do there is push our knowledge theoretically. We know that there's more to a person's well-being than health. And today, a lot of what we heard about was very medically driven, very health focused. But we know that it's the same person that's in emergency departments, that's also potentially known to community services because of disadvantage, and whose children or who themselves might have fallen through the cracks in education. So health, education, social care, very, very important. And then that's the what, but the how in relation to implementation science, the guiding principles that might be able to help us understand how we can do things. We can't ignore all of those principles there. We're trying to piece those pieces of the puzzle together. With literature, it's taking months and months of work. So this is really deep thinking. It's not something we're rushing. Equity in program, in intervention mapping, program development. We were absolutely honoured and thrilled that Dr. Fernandez was able to join us live in Australia, in Melbourne. She was definitely there, and wearing the same jacket. So that's always lovely when that happens, you know. We had a fabulous time with Maria and the infamous Professor Carl May over 2 days. How can we embed equity explicitly into intervention mapping steps right from the very beginning, and also into implementation mapping? That's something we will also be discussing. And to finish off, we're doing this massive review. Our librarian at Monash has never sort of quite heard of anything like it. But we really want to break down silos and identify the in-practice implementation methods used for specific equity outcomes in health, education and social care settings, and consider what equity implementation principles underpin the identified methods. So we've done a lot to date. We can tell you about it at the networking, but I won't go through any more detail so that I can wrap it up and we can get to the networking session. Thank you very much.